continuing our partner organizations who share our strong interest in supporting recovery and especially in bringing education and tools to enable faith communities to provide understanding and recovery support to impacted children and families in their congregations. This series is made possible through support from the Substance Abuse and Mental Health Services Administration's Center for Substance Abuse Treatment. My name is Sis Wenger, and I'm the President and CEO of NACoA, the National Association for Children of Alcoholics, which is the host organization for this free webinar series. Our co-sponsoring organizations are the American Association of Pastoral Counselors, the Association for Clinical Pastoral Education, the National Drug Endangered Children Alliance, and the Entertainment Industries Council, which is also providing the technical support for this 9-part webinar series. Today we want to revisit the subject of opioid abuse and addiction, a subject we covered a few weeks ago looking at the growing spread of opiate use and heroin addiction in our youth. Today we look at opioid use and the management of pain, a long-time accidental addiction problem that has entrapped thousands every year, and we are very pleased to have a renowned authority who has taught and written extensively on the subject, helping us to greater understanding of the problem and its related issues. And now, let me introduce you to Dr. Mel Pohl, medical educator, frequent speaker, author of several important books, some of which we will introduce to you at the end of the presentation, and practicing pain management physician, and the Director and Vice President of Medical Affairs at Las Vegas Recovery Center. Mel, turning it over to you.
Thanks very much, Sis, and welcome everyone. 3 OxyContin a day, 6 Percocet a day, 4 Soma a day, 4 Xanax a day, 3 Ambien at night, 4 Adderall per day. These were the medications that 28-year-old Alicia had been taking pretty much for the last 6 to 8 years. She was also smoking a pack of cigarettes per day, drinking a bottle of vodka per day, using marijuana, medical marijuana, 1 or 2 grams per day, and towards the last 6 months she was using heroin, sometimes with cocaine, and sometimes in the middle of that Suboxone. When she came to treatment at my center, this was what her medications looked like on the desk of the nurse's station. Alicia's history started when she was 7 years old. She was sexually molested by one of her mother's boyfriends. She had been suffering from severe menstrual cramps a few years later, and by the age of 12, she was brought to the physician and given a prescription for hydrocodone, 10 milligrams 4 times a day. She started smoking marijuana and drinking alcohol soon after and was smoking cigarettes within the next year. Her mother, who was alcoholic, died age 16 of cirrhosis. When Alicia was 17, she was at a party and was raped by a number of young men. By 20, she was heavily into her addiction, but she was coupled with a boyfriend, and the 2 of them were using drugs actively. They were in a head-on collision. She awoke from a coma with severe back injury and back pain, and she found out that her boyfriend had been killed in the accident. At 22, she was diagnosed with fibromyalgia, and for the next 6 years, her pain level was 8 out of 10, despite all the medications that she was taking. Alicia had 2 children. She was a single mom. She had trouble getting work and caring for her kids. The crisis in her life came when her sister, who was a primary caregiver in the family, called Child Protective Services because Alicia was frequently noted to be driving under the influence with her kids in the car. She was confronted, threatened with losing her kids, going to jail for multiple violations of the law. But the thing that got her attention and that convinced her to go to treatment was when her sister said, "You're worse than our mother ever was." She came to Las Vegas Recovery Center for treatment. She was not too happy to be there and less happy to come off the drugs, even the prescription drugs, because like many patients with chronic pain, they realize that they have a substance use problem with drugs like heroin and alcohol and even cigarettes, but don't take away my OxyContin and my Percocet because how will I survive? Remembering that Alicia's pain was about an 8 out of 10. We detoxed her from all of the meds that I listed, and within about 10 days, she moved into the rehabilitation program, and her pain was down to a 6 out of 10 from an 8 out of 10. Over the course of the next 4 weeks in treatment, her sleep finally became regular because she had severe sleep disturbance, and her pain level was down to a 4 out of 10. She began to deal with the multiple traumas that she had experienced in her life, and you can imagine what came up: grief, anger, resentment, anxiety, abandonment sensations, and as we see with many people who enter recovery, she started to shift and began to trust other people, began to realize and develop a willingness that she had to change her perceptions, her attitudes, and her actions. She learned about 12-step recovery, about nutrition, about taking a healthy approach to the past, about meditation, a mindfulness practice, exercise, and yoga. She got a sponsor, and after 35 days, moved into a halfway house for another 3 months. Fast forward 3 years, Alicia is clean and sober. Her kids are back home. She has a new and better job. She's less depressed. She sleeps well. She goes to meetings, has a sponsor, and sponsors other women. So what are the lessons from Alicia's story? She had the stigmatized disease of addiction. It's hard not to judge her for her misbehavior, but the bad behavior were symptoms of her addiction. She suffered from multiple traumas in her life. She lost the genetic lottery. Her mom was alcoholic, and unbeknownst to her, her dad was a heroin addict. She was exposed early in her life to multiple drugs: nicotine, marijuana, alcohol, and soon after started with pain-killing medications and eventually became hooked on the strongest of painkillers, heroin. She was trying to take away her physical pain and also her emotional pain. Inadvertently and without realizing, the drug became the primary drive, and it developed survival salience. That means the brain found the drug more important than her kids and her ethics and her morals. She experienced the bottom finally at the thought of losing her kids and being like her mother, and she entered treatment and began the process of change. She continues to do ongoing maintenance therapy, and a day at a time, her life continues to improve. This is the good news story of recovery with co-occurring pain and addiction. So I want to tell you 5 of the most important things that I know about chronic pain this morning, and we'll expand on them as the hour proceeds. The first fact, and probably the most important thing I can say this morning, is that all pain is real. We'd like to differentiate real from what? Imagined pain, falsified pain. You know, the pain literature is replete with information about legitimate versus illegitimate pain. And one of the sources of confusion is it real or is it emotional? The second key point is that emotions drive the experience of chronic pain, and unless and until the emotions and the thoughts around the issues around pain are dealt with, we are not going to see people improve. And there's some physiologic data that supports that premise. The third is that opioids often make pain worse. Alicia's a great example. She started out at an 8 out of 10 pain level with crazy high amounts of opioids, and by the end of her treatment, her pain level was 4, and 3 years later, her pain level is insignificant, usually 2 to 3. And she's got back disease and a chronic condition known as fibromyalgia. But over time, the opioids backfired in her, as they do in many people who are attempting to get relief from a chronic, unrelenting condition of pain. The fourth issue is that if we're going to treat someone, let's make them better. It seems logical, but what so often we use medication to decrease the pain, and what we end up is someone with less quality in their life. They're not working, they're not up and out of bed, they're falling asleep in their suit, they're embarrassing their families, and their life is shrunk as a result of the opioids. So if we're going to do anything to treat pain, we have to make people more functional, not less functional. And the last is that expectations influence outcome. We have a lot of data about optimism and the fact that people who believe something is going to work shows that it works, and that's actually the placebo effect, which we know is very valid in at least 25% of people. there's an expression that we use here at the center, which is there's more right with you than wrong with you. And it really just sort of shifts the focus from poor me and how terrible I am and how nothing is going to work. And of course, that's the basis of hopelessness, into I have an opportunity to change my life and have a better life. If everybody's experienced pain, the basis of pain is that it's unpleasant, and it's both a sensory and emotional experience. So we feel it in our body and we feel it in our brain, and we suffer because of the emotional response system. The purpose of pain is to associate with actual or potential tissue damage. So we want to know if there's an injury or if something is damaged so that we protect it. If you've sprained your ankle, you don't walk on it because it hurts. It's a signal, it's a functional signal. That's really associated with a phenomenon of acute pain. What we're talking about today is, of course, chronic pain, which ends up being rather maladaptive. So it's a pain that really doesn't help in the way that it was meant to. There's a lot of things that influence pain. One of them is culture. The culture that you are raised in influences how you experience pain. I was raised in a Jewish household, and I know a lot about pain, and I like talking about it. So I'd like to spend the rest of the hour telling you about my back. Of course, Sis wouldn't appreciate that, so I'll move on. But you know, there are people who are stoic, and it's just incidental that they have pain. And you would think that they're strong-minded when in actual fact they've been trained not to pay attention to the pain. Even though my back hurts, in the context of working, I go on with my business and my back pain goes away. So the context is really important. What I think is going to happen tends to happen. So if I start a message in my nervous system that, this 4 out of 10 is going to be a 6 out of 10, and then I'm not going to be able to concentrate, and then I won't be able to do my job, I'm going to do a whole lot less well than if I just take a breath, notice that there's a strong sensation, and change the way I operate in the world. We had a patient who came to us with chronic headaches. We told her that she had to go to group. She had a 10 out of 10 pain, and she was sure that her head would explode if she went to group because she had fear, anger, and anxiety related to being forced to do something that she didn't want to do, and she had a series of distorted thoughts, cognitive distortions we call them, where she was convinced that her head would explode or that the pain in her head would kill her. And those very powerful messages have an influence on how much pain somebody has. This next slide is fairly complicated, and you start at the bottom of the slide and see that there's a nail in a person's finger. The enlargement just to our left is the nail sticking in the epidermis. There are chemicals causing the pain receptor to fire. It interacts at number 3 in the spinal column, and then it goes straight up to the brain. We have to have an intact connection along the spinal column into the brain. And as you can see, the thalamus, or that little brown ball in the large circle on the right of the slide, transmits the circuit to the frontal cortex, where we have distorted thinking, to the somatosensory cortex, where we can outline where this is occurring, and to the limbic system, which is the site where all emotions are driven from. So immediately with an acute pain, we have an emotional response. It's aversive. We want to get away from it, and in order to get away from it, we take the nail out, and the tissue will heal, and that's the end of it. With chronic pain, it doesn't end. So here's the transient activation of a nail in the finger, or surgery, or inflammation. With chronic pain, let's take as an example my back pain. There's a bulging disc pressing on a nerve, and it continues to fire from my back, and it activates not only my nervous system, which winds up and enhances the signal, but it changes my brain. So the real issue with people with chronic pain is that they have a different brain than they did when they started. And we actually have data that says that people who have pain less than a month, the brown thalamus lights up, and people who have chronic pain, it's the limbic system. So chronic pain becomes a different phenomenon, and as I mentioned, it is maladaptive. My back pain doesn't protect me from doing anything. I can climb mountains, I can stand on my head, I can lift weights, but it's a source of aggravation and frustration, which is what chronic pain really ends up being. The last point about how people feel pain is to say that the sensory experience, which is on the left of the slide, nociception, becomes the overall experience of pain, which includes the emotions and the thoughts. and it's related to an enzyme system called COMT, catechol-O-methyltransferase. COMT metabolizes dopamine. Dopamine, some of you may know, is the neurotransmitter of well-being. We know that there are variants of COMT, some of which rapidly cause a sensory experience to feel painful, and others where it's a very slow transmission. So there's different types of enzymes, different experiences of pain. Fibromyalgia is basically getting poked in the chest and feeling excruciating pain. We might say that that's exaggeration or being a wuss in a judgmental way, but what it really is, it's a physiological phenomenon, and it results in certain people feeling more pain than others. Now, there's two things that influence COMT. One is genetics. We are born with a different sensitivity to pain, and that is genetically transmitted. The second is the experience of trauma. People who have had trauma, whether it's physical, emotional, sexual, veterans returning from military combat, first responders, and even young babies who were born prematurely and placed in a neonatal unit untouched by mom, end up traumatized, having a different COMT, and having a heightened threshold, a heightened sensitivity or a lower threshold to the pain experience. We know that emotions are really characteristic of the overall experience of pain, and so we're talking about I sprain my ankle and then I get upset, I sorrow, grieve, lament, beats his breast and becomes distraught. So he feels two pains, physical and mental, just as if they were to shoot a man with an arrow and right afterward were to shoot him with another one, so he would feel the pain of two arrows. And that was said 2,500 years ago by the Buddha. So this is a very old story. And unfortunately, in Western culture and Western medicine, we discount the emotions. And we say there's, it frustrates me because it's as if it's not real when you and I know that our emotions are just as real as the throbbing discomfort in my bulging disc. Chronic pain syndrome results in some patients, not everyone. There are some people that have pain and they go about their business. Those with chronic pain syndrome end up in a program like mine in Las Vegas. They have depression, anxiety, anger, and fear. Their daily activities are restricted, so they're not functioning well. They're using medications excessively in medical services. They take tests, they go for new tests, and they want surgery to fix failed surgeries. And these are people that have sometimes had 3 and 4 and 5 surgeries. And there's no clear relationship to the organic disorder, so we kind of get into that bind of is it real or is it not. One of the things that frustrates us about pain is that there's no pain-o-meter. It's whatever the patient says it is. What's your pain score on a 0 to 10? And the only way is unless it's proven otherwise, and there's no way to prove otherwise that somebody has a level of pain that they have. Totally subjective. And yet we try to use that as a measurement of somebody's well-being. We at the center use a 20-question test. It's a self-administered test, and it looks at pain intensity now and over the last week, but also mobilities, activities of daily living, affect about mood and depression, and vitality, and then 2 questions about fear. We found that fear and negative affect are the drivers of people taking opioids and having more pain. So if we want to make people better, we want to maintain or improve their function. That's the reasonable goal of pain management. And unfortunately, pain docs are looking to decrease pain primarily. A reasonable pain goal is reduce the pain by 50%, but that's not the focus of the pain treatment. There are a lot of medications that treat pain, NSAIDs like ibuprofen or COX-2s like Celebrex. I had a patient who took ibuprofen after he had his wisdom tooth pulled. He'd been dependent on methadone, and when I told him to use ibuprofen, he called me back the next day. He said, "Oh, doc, that ibuprofen, the only thing it did was take the pain away." So think about that. Medicines in the antidepressant family, tricyclics like Elavil or amitriptyline, nortriptyline, Pamelar, help with sleep and diminish serotonin. The SNRIs, Cymbalta or duloxetine, Effexor, venlafaxine, work on serotonin and norepinephrine and decrease pain. Medicines for seizures also decrease pain, especially the nerve pain related to diabetes. Neurontin or gabapentin and Lyrica, pregabalin are 2 of the common ones that are used. Muscle relaxants may or may not help, but Soma is a bad drug. So one take home for this morning is Soma carbidopa is an anti-anxiety drug, terribly addicting, very unsafe, very habit-forming. And the last is things that we can put on our skin, like creams and gels, lidocaine, Neurontin, ibuprofen, all come in those forms and can be very helpful for chronic pain. If we're going to use opioids, we ought to see how they work. This is a simple premise. Let's try them. Let's limit the time that we use them. If people remain functional and ongoingly we assess that they're functional and their pain has gone down, we're in business. What often happens is they work for a while, the doses, the patient develops tolerance to the dose, and the dose goes up. And then the potency of the drug goes up. And then we add a sedative to the pain medicine because the patient can't sleep. And that's the time to use an exit strategy. I mean, nobody would take off in an airplane without landing gear. And that's what we end up doing with this opiate system. And we've entered into a really serious time of opioid epidemic. There are side effects to opioids, constipation and cognitive slowing, not being able to think normally, also immune system problems and problems with hormones, particularly estrogen and testosterone. Everybody needs more over time. Some people need more than others, but everybody develops tolerance, and when you try and stop, you can't. People become less functional, and certain people are perceiving their emotional pain as physical pain, and they're treating that emotional pain with these medications because, you know, if you line up ibuprofen against hydrocodone, ibuprofen has the same pain relieving effect. Hydrocodone causes a decrease in anxiety and fear, and that's what people are ending up taking them for some of the time. And we know that some people have more pain on the drugs than off them. On this next slide, you can see that the optimal dose is just in the middle of that curve, and if we go beyond, let's say, 6 hydrocodone or 8 hydrocodone or 4 Percocet a day, we end up on the right side of the curve having more pain with a higher dose of opioid. And in Las Vegas at the Recovery Center, we take people off their opioids, just like Alicia, and pain levels go down substantially. As I mentioned, we are in the midst of an epidemic, and these next series of slides show admissions for treatment of non-heroin opiates, and it's going to be from 1999 to 2009. And just look at the red states. Those are the states with the highest incidence. So wherever you're listening in from, look for your state and just look at the trends in the United States. We're now at 2007, and by 2009, almost every state in the union is red. So this indicates that people are using these drugs, they're overusing these drugs, they're becoming addicted, and they require treatment. They're also dying. 40 deaths per hour in the United States. More deaths than cocaine and heroin combined. More deaths than motor vehicle accidents in the United States in the past 3 years. Pretty staggering statistics, and these overdose deaths are often accidental. We know that the higher dose of morphine, so if you look to the bottom, that 11.18 is people over 100 milligrams of morphine equivalent a day. It's a pretty hefty dose, but I see 60 to 80% of my patients are on that kind of a dose. And you can see graphically that if you get over 99, the jump is substantial, but look at the jump from 49 to 99. There's a substantial increase in risk with increasing dose of opioids, and this is death, hospitalization, unconsciousness, or respiratory failure. We know that as treatment episodes go up, the death rate goes up, and that correlates directly with opioid sales. So one of the reasons we're in the place that we're in is that physicians received education that opioids for non-cancer pain are fine. You know, we use them for cancer pain. People had terminal illness. We used studies that lasted about 3 months, which was the average length of life for cancer when we did these studies, and we transferred that information to this whole population of 125 million Americans who are suffering from chronic non-cancer pain. And we were told 4 lies. The first one was that we physicians are needlessly allowing patients to suffer because we're opiophobic, so give more drugs was the message. Opioids are safe and effective for chronic pain. We have absolutely no proven evidence. We have a lot of studies about the negatives. There is no study beyond 3 months that suggests that opioids do substantial benefit for somebody who takes takes them for chronic pain. And the knowledge and the common beliefs now is that opioids are in fact not safe and effective for chronic pain. The third is, if anybody's in the field of addiction treatment, that opioid therapy can be easily discontinued. And they told us messages like, if it's taken for pain, you don't become addicted, because opiate addiction is rare in pain patients. Now that is the biggest ball of poppycock that I've ever encountered, but many, many physicians still believe this lie. And it was based on a study. Here's the study: 4 cases of addiction among almost 12,000 patients treated with opioids. As you can see, it was done in 1980. I would imagine many of you weren't alive in 1980, but this is the study that's cited. And this next slide shows the study, and this will be up for you to read more, but this was it. This was a letter to the editor of the New England Journal, and as you can see, middle of the slide, 11,882 patients in a hospital received at least one narcotic preparation, and only 4 cases of reasonably well-documented addiction. That means the word addiction was written in the chart. It has nothing to do with what we're talking about when we expose people for months at a time, and they end up on these drugs for decades. So this bogus representation of the truth really led us to a chronic overprescribing, and this is an industry. 2013, $12 billion made from prescription painkillers. They do it with advertising. The United States has 4% of the world's population and consumes 80% of the world's opioids, 95% of the world's Vicodin. This is how it's done. Joint Commission says not only do we have to check blood pressure, pulse, temperature, and respiratory rate, we have to get pain scores on everybody. And I've spoken to many, many nurses around the country. What do you do when somebody has a pain score that's high? You medicate them. And now, as you know, and I know this was the topic of a webinar a few weeks ago, heroin has had a resurgence, and this is very concerning. As we make it harder to get the opioid drugs, since they're no longer indicated as safe and effective, the scheduling of hydrocodone has been increased to make it harder to prescribe. Heroin has had a resurgence, especially in our young people. They were using prescription opioids. Now heroin is cheaper, more potent, and more readily available. And this is the death curve. The analgesic opioids, painkillers, has leveled off in 2013, which is good news, but the heroin curve, deaths from heroin have risen astronomically, and it's the tip of the epidemic. Suboxone, I don't have time to really go into the details about Suboxone. It is a medication that is opioid, buprenorphine. It works on the same receptors as the other opioids. It seems to work a little less directly, seems to get people a little less high, seems to have an effect on pain, but all of those seems to be, don't always hold true in utilization of Suboxone. And as I mentioned, Alicia had a supply of Suboxone, as did Philip Seymour Hoffman, which, as I understand it, he and I know that Alicia was using when she was unable to get the drug that she really wanted, which was the heroin or the Oxycontin. So Suboxone holds some promise for some patients to stabilize their opioid addiction, perhaps some patients to stabilize their pain condition, but it is not the panacea that we had hoped for. This is a drug for opioid overdose. So it's basically Narcan in a self-administered form. Many states have authorized this to be carried by first responders and have suspended criminal penalties for its use. This prevents death. So if somebody has inadvertently overdosed or purposely overdosed, if they're injected with naloxone, which would happen in an emergency room, having this on hand in an emergency will cause people to live longer and have an opportunity to get well. So what's the difference between being addicted to painkillers and just really, really liking them a lot, this man says to his doctor. The truth of the matter is diagnosing addiction in the presence of pain is complicated. One way to diagnose addiction is if people are smoking. Smoking, of course, is tobacco addiction or nicotine addiction and needs to be diagnosed accordingly. The short definition from ASAM, the American Society of Addiction Medicine, and you can check for the long definition at asam.org, is that addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction of these circuits leads to characteristic biologic, psychological, social, and spiritual manifestations. And here's the key sentence. It's reflected in an individual pathologically pursuing reward, which we might think of as getting high or feeling good, and or relief. And that's the key. People with chronic pain who develop addiction are pathologically pursuing relief from physical pain and from the consequences of emotional pain. And they do it with substances and they do it with other behaviors, which is included in the ASTEM definition. So that differentiation between, on the left, pain patients, legitimate pain patients, put that in quotes, the good patients, versus those addicts, those drug abusers, as two separate entities, really is not accurate. And what we see is that there's a substantial overlap between pain patients and people who develop addiction. We know that 63% of patients admitted to using opioids for purposes other than pain, and those are people with pain. So that means I use them to sleep, I use them because my marriage gets better, I use them to calm down. 35% met DSM-5 criteria for addiction. And we don't have time to go into the details of the DSM-5, but tolerance and physical dependence are excluded from diagnostic criteria if the drug is prescribed by a doctor, and still 35% met this criteria. And last is that of the people who died, 92% of opioid overdose decedents were prescribed opioids for chronic pain. So the dichotomy is false. In the last few minutes, I want to talk a little bit more about which emotions and how emotions really become magnified and end up causing pain. So the 5 key emotions that we see in chronic pain are guilt. I've never met anybody who's come into the pain program who hasn't reported that they feel like they're responsible for their pain. Often it's related to a situation that occurred. We had a firefighter who was unable to save a baby from a car that was sinking. He saved the mom, the baby drowned. He didn't even know the baby was in the car. 6 months later, he injured his back in a training exercise. 20 years later, he had overdosed and attempted suicide and was addicted to opioids, came into treatment, and after detox, about 2 weeks in, he started having intrusive nightmares about his failure to save that young baby. And of course, there was nothing he could have done. Claudia Black would say that's false guilt. But it was guilt nevertheless, and it consumed him until he was able to see it for what it was. Anger and resentment. People are angry with their doctors. They're angry with their family. They're angry with God. They're disappointed that they can't do the things that they want. They're angry with themselves. And that anger fuels the experience of chronic pain. Loneliness. This is an extremely isolating condition. People end up on their own because they don't relate to other people. Even these people, when they go to treatment for addiction, they go in and what they see is that they're different than everybody else. And sometimes in a treatment center, they'll hear, oh, it's not the pain, you're an addict and you're in denial. Well, that's not really true. People with co-occurring pain and addiction have 2 problems and both have to be addressed. And one of the things that's most remarkable here at the center is to see people hook up with other people who have very similar conditions and end up getting support and encouragement and identification for the 2 illnesses. Helplessness is really characteristic. There's nothing I can do, and I'm destined to be in this state forever and get worse and eventually die. And it does feel like there's nothing that can be done. And of course that's an interpretation, but it is not the truth. And last is fear. Fear drives the experience of pain, fear that it's going to get worse, fear that it won't get better, fear that I'm going to get worse. And certain people have a tendency to turn the lens outward and catastrophize, that actually the pain becomes more significant than it actually is. We know that fear is often related to pain in the sense that when I move, it hurts. So if it hurts when I move, my response will be to avoid movement. I also have a rotator cuff in my right shoulder. If I go beyond 90 degrees, I get an ache. If I don't go beyond 90 degrees long enough, after a while, I won't be able to go beyond 90 degrees. And then I won't be able to put my shirt on without assistance. And then I'll feel bad about myself, and then I won't want to go anywhere, and the pain will get worse. So escalating fear drives the experience of chronic pain. In order to reduce pain intensity, we want to work with all the measures that I talked about, both the emotions and the thoughts. And one of the most effective and well-studied techniques is cognitive behavioral therapy. So we're talking about dealing with all or none thinking and black and white thinking and that tendency to catastrophize. People have these cognitive distortions. My back is killing me. Well, no, it's not. You're not going to die. I have a nurse practitioner I work with who loves to say, what's the cause of death going to be on your death certificate if you're dying from back pain? But we tell ourselves that message, and it's a very powerful message. So CBT, in short, is an unraveling of some of those faulty thoughts and really gaining some skills in not ratcheting up, but rather ratcheting down the thoughts that lead to negative emotions. Dialectical behavioral therapy, of course, works with distress reduction and also with mindfulness practice. We're very interested in that. Most of our patients have high levels of distress. Most of our patients have had traumatic experience in their lives. ACT is acceptance commitment therapy. Stephen Haynes from the University of Reno wrote a wonderful book about ACT and pain, and it's basically based in function. So find things that are valuable to you and then commit to acting those out. I had a patient who had, he was very despondent. He was 64 years old. He had forcibly retired, and he had nothing to live for. And I said, well, if you had your druthers, what would you do? And he said, well, I'd go fishing, but I can't fish. Why can't you fish? Well, because I have to stand, and after 10 minutes, my back starts to kill me. And I said, well, what if you brought a camp chair and sat in it while you fished? He said, oh, what would people think? So that was our work. You know, that was the area of the work. He ended up going fishing, teaching his grandson to fish, and he has less pain because he's committed to that function. We know that being distracted from pain causes a decrease in pain level. I haven't had any pain until I brought it up right now because I've been distracted and concentrated. A sense of control is the basis of the placebo effect. And one classic study is they gave people a joystick, like a Jeopardy stick, to press, and they said, if you press this stick fast enough, we're going to give you an electric shock, you won't feel it. And people pressed the stick, and then they measured not only their pain scores, but also their brain activity. And they found lower pain brain activity and lower pain scores when people were able to press the stick. And the stick wasn't attached to anything. So it was a placebo effect that translated into a therapeutic effect. Reducing fear reduces pain. And we work really hard with people to see the difference between hurt and harm. So let's take my shoulder as an example. If I exercise and I stretch and I move, even though it's uncomfortable, if I move to the edge of the stretch, eventually I'm going to get my hand over my head and I will have increased mobility. As a result, my function will improve. I will feel better about myself, and the level of my pain will be reduced substantially. So it's really about the reversal of what's called the fear avoidance cycle that we're really focused on. I'll share 3 pearls about pain, and this relates to families. We know that conditioning increases pain. There was a classic study of a person with back pain. He was hooked up, or she was hooked up to an electric shock machine, given a shock on their back. And then their pain score was measured, and their EEG activity related to pain was calibrated. And they did this in the presence and the absence of what they called the solicitous spouse. Solicitous spouse is a husband or wife that grimaces when the shock is administered and that rubs their hair. In the presence of the spouse, double the pain score. So what that means is not that people are faking their pain to get attention, but I get attention when I have pain. Therefore, I have more pain to get more attention. It's almost like Pavlovian training. Pain patients are a pain, and this refers to the fact that we are socially circuited, so that we have what are called mirror neurons in the somatosensory cortex. When I see you get shocked, even though I might not know you, I will have a response in my brain that will be a perception of what you're experiencing. And it's one of the reasons why people who treat people with chronic pain tend to get burned out. So this is a tough field. The work that I do here is done with a strong team of professional clinicians. And the last issue is that secondary gain prevents getting well. Secondary gain are not things that people are consciously gaming for. They're things that benefit the person. And I run a group at the center with our pain clients, and what I tell them is, tell me how pain serves you, how it works in your life. And they get kind of, gnarly looking, and they say, what are you talking about? I'd give anything to have my pain gone. And then somebody will say, well, I never have to go shopping. Somebody else will say, well, I haven't worked in 5 years. And somebody else will say, I don't have to get up with the kids at 4 a.m. to go to soccer. And then somebody will say, I get to take as many drugs as I want. And then we're off and running on a very provocative conversation. So it's not like people are doing it on purpose, but they end up gaining something, and that promotes more pain. I actually personally went to the doctor. He said, I can cure your back pain, but there's a risk you'll have nothing left to talk about. I can't hear you laughing, but I know you are. So when we look at treatment, it's really about changing from forced attention and distress and anxiety and anger to, taking a closed fist and just opening it. First step, for those of you that know the 12 steps, is I give. I'm powerless over my pain. Utilizing body awareness with relaxed attention, but not judgment. So one last time I'll mention my back pain. Noticing that my back hurts without any of the story, and taking a breath and really allowing the muscles of my back to relax and settling in. Being involved with others is absolutely critical. The most important things that I see are people communicating with each other and identifying with each other and walking the track and starting to laugh and get involved. Pain Recovery is the name of one of my books, and it's about developing balance in our thoughts, our emotions, our body, and how we function physically, and spirituality. And the spirituality here starts with a connection with other people. Certainly higher power and God have a good place in many people's lives, but it's really about moving beyond that self-centered identification of this is me, this is my life, this is how I suffer. And as we move out and find balance in those 4 areas, we will have resulting changes in our relationships and in positive actions and behaviors. We do a lot of non-medication treatments, and I write about these in the Pain Antidote. It's really about getting moving. So exercise and physical therapy, with or without a professional. It's a good idea to get started if you're immobilized, with some assistance and some guidance. We have a chiropractor who comes 3 times a week. Patients get massaged once a week if you're lucky enough to be able to access that. Reiki is an energy technique. Acupuncture, of course, clears out the energy channels with needles, or acupressure. We have a whole section in the book about acupressure points. Individual and group therapy is key. And lastly, mindfulness-based stress reduction, which is John Kabat-Zinn wrote a terrific book called Full Catastrophe Living, and it's a technique of really scanning the body, noticing tension or discomfort, and just allowing it to be there without judgment and using the breath. We do have a yoga instructor and a Qigong instructor, and I'll just close with some comments to say that research does confirm that the drugs give the same benefits as yoga. This is a back pain, insomnia position. If you're a yogi, you know the pose, and you can see the fellow on the right has it pretty well down. The balasana, or child's pose, he can't get his hips down, which I have the same problem when I do yoga. And the last is savasana, corpse pose, total relaxation, and he has perfected that technique, as has the woman on the left. So I'm going to stop and leave some time for questions that have been sent to the administrators and to SIS, and I'll do my best to answer them for the next 10 minutes, and then I'll close with some final comments.
Thank you, Dr. Pohl. Fascinating information that is useful to so many people, professionals and individuals. I have several questions for you. The first one is it safer to take less pain meds than prescribed to reduce a worry of developing addiction?
Well, it's a complicated. I have a complicated answer to a simple question. So I think it's safer to take a minimal dose of pain medications, whether or not addiction is on the table. Because remember, I've been talking both about addiction, but also about what we could refer to as complex dependence. People who go to the doctor and take what's prescribed, which is really the case in about 60 or 70% of patients who are getting into trouble. So I think, staying under that 100 milligram morphine equivalent, and if possible under 50 milligram morphine equivalent, is one of the standards. But if you've got addiction history, or if you have a family history of addiction, or if you find yourself medicating emotional pain with medications, I think you're in potential trouble. And my approach to this is to take the medication down as low as possible or eliminate it.
Here's a related question, and you've partially covered it in your presentation. And the question is, are there steps to take when dealing with acute pain to prevent the development of chronic pain?
It's a brilliant question. I wish we knew definitively. One of the real keys that we've just learned in the last 2 years of research is that smokers, cigarette smokers and vapor smokers who have exposure to chronic levels of nicotine develop chronic pain more frequently than non-smokers. So if you are a smoker and you're having surgery, it really behooves you to look at eliminating cigarettes from your life. The rest of it is much more confusing, Sis, and I wish I had a definitive answer. There's some theories that say give lots and lots and lots of opioids so that the pain center is suppressed and you don't have pain. And then there's confounding data that says if you take high-dose opioids during acute pain, that predisposes to chronic pain. So I am sorry to say I don't know the answer. My philosophy and approach for acute pain is certainly medicate with opioids if necessary, use as little as you can for as short a period as you can, stop them and go to non-opioid medications so that that chronic cycle of taking medication for the pain doesn't get set up.
That sounds like great advice. I have another question. If I am taking a prescription in a house and living in a household of kids, what is the wisest thing for me to say to the children about prescription drugs?
Yes.
And I think this is a question that people who are working in faith communities and trying to guide parents who have come to them for help, for example. I think we both need to know. The clergy need to know, the counselors need to know, and the parents need to know. What do you tell parents to say to their children when they're taking pain pills?
Absolutely. Well, so the first point is lock those medications up. The first source of medication that gets abused by young people, and we're talking about over 13 years of age, sometimes younger, is parents' medicine cabinets. So free access to those medicine cabinets is a huge mistake. Now, what do you do with behaviors associated with chronic use of opioids? I think the message is like with anything. I mean, for parents who drink alcohol, or for parents who are now going to dispensaries smoking marijuana, I think it's risky to normalize that behavior for youngsters, because youngsters use drugs when they perceive risk is low. So optimally, the parent would not be on an opioid. If they are, I think they shouldn't hide it. I think they should be direct in their discussion of it and explain that they are dependent on these drugs. They use them for this particular reason. They wish they could stop. They certainly don't think it's a good way to live, and they wouldn't want that for their children. But, my opinion is for chronic pain, there is rarely a reason to stay on opioids, and particularly when they don't enhance function.
So I think I'm hearing you say that in the short term that they work, but in the long term that parent needs to get other kind of help.
Absolutely. I mean, yes. I mean, that's totally well said. We're talking about long-term, we're talking about lifelong pain here. We're not talking about a condition that's going to get well and the need for the medicine is going to stop. So we're looking at decades of taking these medications, developing tolerance, having a decrease in effect, having the hyperalgesia effect where you have actually more pain on than off, having a ton of side effects, and really diminishing returns. Now, let me back up and qualify and say, if you're taking 1 or 2 hydrocodone a week or even a day and you're working and you use those medications to diminish your pain and you have not escalated the dose, I'm really not talking to those kinds of people. I'm talking to people who have a steady dose, whose dose is increasing over time, and who are unable to stop.
Thank you. And if you have a family member who is in recovery, can a doctor work through a medicine management plan to help eliminate the need of the opioids quickly?
You want me to answer quickly?
No, I want you to, can the doctor do it quickly?
Jeez. Well, one of the problems is, what I recommend to physicians when I teach physicians is to get under that 100 milligram equivalence of morphine a day. So that requires weaning down of the dose. Rarely can that be done rapidly unless it's in a place like mine where they can actually detox with medical supervision and access to medications. Weaning is tough because every time you drop the dose, the patient is in withdrawal and the pain level goes up. So typically it goes slow, it goes over a long period of time, and I think the real keys for patients who are trying to do that and doctors who are trying to guide them is finding support, learning how to do mindfulness practice, steady exercise, stretching, yoga, positive attitude, cognitive behavioral therapy, all of which can be learned on your own, although they can also be taught by professionals.
Do you anticipate in the next 5 or 10 years that a critical mass of physicians will understand what you've been talking about today and change the way they practice?
Gosh, I sure hope so. I mean, that is my life's work, and the last part of my professional career is trying to send this message out. And you know, the real problem, folks, is that if you're a physician prescriber and you have a patient with chronic pain showing up in your office, you don't have much to do for them. So the natural response is to pull out the prescription pad and use something that appears to be effective and that, you know, you've been sold a bill of goods as effective, but really isn't in the long run. The American Academy of Neurology just published a very astute review of opioids, and the message is there. The National Institutes of Health have come out with a study based on a 2-day seminar. I think that the message is getting out more. I think it's a hard one to internalize for prescribers because we don't have much else to do.
We are getting fairly close to the end. We have a few wrap-up things, Dr. Pohl. I wonder if we can discuss the books that we've asked you to put on your PowerPoint for us.
Okay, so what I'm going to do is I'm going to remind us of the 5 key facts which are on your slides, which is renal. Emotions drive the experience of chronic pain. Opioids often make pain worse. If we're treating, we got to treat to improve function, and expectations influence outcome. And I will tell you, this is very hard work. I have a little cartoon of a woman who took her husband to the doctor, and the doctor's saying, your husband's suffering from a severe stress disorder, he has chronic pain and addiction, but he's going to regain his health completely if you do the following. Cook him 3 good meals a day, nutritious lunch, candlelight dinner, enough rest, take him to the gym, have sex with him once a week. If you do all these things, he's going to regain his health completely. What did the doctor say? You're going to die. So obviously, we don't expect that this poor guy's going to die, but this is really hard work for clinicians and for families and for the patient with chronic pain. So that's where I'm going to close and say thank you very much. And there's some photos of my books, which, Sis, you're going to introduce, I guess.
Yes, I wanted our audience to know that this is not brand new information, but it's new additions to information we've had for a long time. Dr. Pohl has been one of the leading people working in this country, not only to educate doctors, but to help patients understand that you can heal from or handle chronic pain without becoming addicted. And Day Without Pain is one of those books. So the next slide, please. And then this book is about finding balance in life in order to reduce the suffering. So while chronic pain may not go away, there are strategies that individuals and referring physicians can recommend. And finally, the one that I love is Pain Recovery for Families, how to find balance when someone else's chronic pain becomes your problem too, because of all we are learning from the Adverse Childhood Experiences study and the chronic pain for people who grew up with chronic emotional stress as childhood and paying for it with illnesses, mental illnesses and physical illnesses later in life, that much of that is coming out. So I was delighted that Dr. Pohl had this book. And you have one more coming out, don't you? The Pain Antidote, the proven program to help you stop suffering from chronic pain, avoid addiction to painkillers, and reclaim your life, with Catherine Ketchum, who is another prolific and wonderful writer. I assume that we can get all of these books on Amazon, from Borders.
Amazon, yes, Amazon bookstores. The Pain Antidote is out, and it is just out for the last month, and it really reviews most of what I've been talking about today.
Terrific. So those are wonderful resources for our viewers today. Well, thank you very, very much. For the hundreds of participants on this webinar, let me extend our deepest thanks to you, Dr. Pohl. You've really given us a powerful presentation on opioids, addiction, and pain management. And I think it's critical information for anyone wanting to understand a problem that is growing in this nation and touching so many lives. We have, I want to now invite our audience to mark your calendars for July 28th at 2 p.m. Eastern Daylight Time, when Deborah and Jeff Jay, who are nationally renowned authors and trainers on intervention, will discuss the process that helps whole families begin taking steps to healing while they work together to encourage an addicted family member to accept treatment and recovery help. If you want to read anything ahead of time that would pertain to what the Jays will be covering, they have a website that's called lovefirst.net, and it'll give you some introduction to the topics that they will be covering. Finally, when you close your viewing window today for this live webinar, a new window will automatically pop up where you will have the opportunity to provide us with feedback about the presentation. Please take a few moments to give us your feedback. And my last announcement is that Dr. Claudia Black, who did our first webinar where we had some technical problems, will repeat that webinar on August 4th, Tuesday, August 4th. And mark your calendars for that, and you will be able to get the entire one that was interrupted a bit the first time around. With that, I will conclude today's webinar. Thanks to all of our participants, to the Entertainment Industry Council for their terrific technical support, and especially to Dr. Pohl for very informative and helpful presentation. Thank you all.